Good morning, everyone. Was that too loud, Dan? Oh, okay. Good morning. It's a privilege to be speaking to all of you today. I'm a thoracic surgeon, and I thought what I would do is sort of for patients and caregivers kind of give you a background of how to think about surgery and some of the things that we think about from our end. I have no conflicts to report. I will give the disclosure that to a great extent, especially when you're talking about surgery for mesothelioma, and I'll make this point throughout the talk, a lot of what I'm going to tell you is based on my personal experience of doing this for the last 25 years. So what I'll give you is my take on what a patient or caregiver should understand before considering surgery as part of their treatment for this cancer. And I'm talking about pleural mesothelioma, not peritoneal. And then if time allows, we have some case studies that we could do, and then I'll try and answer any questions as best we can. So, selecting patients for pleural mesothelioma surgery. You start with this. There's different roles for surgery in the field of medicine. So take appendicitis. If you go to the emergency room with appendicitis, it's a pretty short conversation. You can have surgery or you can die of appendicitis. Pick one. So it's the only treatment. Then take something like early stage lung cancer, where if that cancer hasn't spread and you can see it's contained within that part of the lung, if you take that out, you can cure someone with surgery. So we know, because lung cancer surgery has a great staging system, that if you're a stage 1, your best chance of cure, black and white, is going to be to have surgery. Pleural mesothelioma is neither of those. It just doesn't fit into that category. And the issue is that you cannot achieve a microscopically complete resection, meaning that you can't remove all of the cancer. There's going to be, because it lines the surface, all the surfaces in the chest cavity, even after the most aggressive operation, there's still going to be invisible or microscopic disease remaining. And the analogy I'll sometimes tell the patients is it's like scraping paint. It can look like you got everything. If you go up there with a microscope and take a look, somewhere you're going to find a paint chip. So if you're doing surgery for mesothelioma, you have to combine it with other treatments because you cannot cure someone with surgery alone. So here's some facts about it. Surgery for pleural mesothelioma, let's be clear, I tell this to every patient, it is not standard of care. And I'll talk about this MARS-2 trial in a moment. But basically, some people, especially in the UK, might make the argument that surgery is contraindicated because of the latency period between asbestos exposure, which causes mesothelioma, and when you develop the cancer, most of the patients are higher or older, which means they're going to be higher risk. Achieving a macroscopic complete resection, which is the goal of these operations, it's a colossal operation, whether you spare the lung or take it. The current staging system, which you just heard about, does not account for some of the most important things that we as surgeons look for to say, yes, you're likely to benefit from this. So we're talking about selecting patients without an accurate staging system for a colossal operation that is not standard of care and is typically conducted in an older, higher risk population, right? So this is a big deal sort of decision-making thing. So here's what I think needs to happen for a patient to have surgery. The patient needs to be a safe candidate for the operation you're planning. It has to make sense from an oncologic, from a cancer perspective. And the patient must give informed consent. And again, this is not standard of care treatment. So, these office visits for me are often, hour and a half, 2 hours. I have to go to sleep at night knowing that if a patient signs up for this, they understand exactly what they're getting into. So how do you select patients who might benefit from surgery? Well, let's start with the first one, being a safe candidate. And the short version is you basically have to be fit enough to tolerate the surgery. And there's 2 operations we do. There's one where you take the lung out, and there's one where you save the lung. Personally, I just do the latter. I do the other one for other cancers, but not for mesothelioma. You have to be, taking out a lung is just like you would expect. You have to be, more fit, more robust, have a better performance status and everything else if you're going to take a lung out. So if that's part of the procedure that's being offered, that's sort of a higher bar to cross as far as your fitness. Here's what gets sticky. It has to make sense from a cancer perspective. And here's the big problem. You just heard about the TNM staging system. And again, lung cancer, breast cancer, colon cancer, If you tick off those things, the tumor, the nodes, and whether or not there's metastases, you know what the right treatment's going to be. Our staging system doesn't account for the two biggest things, at least in our series and in most, that will prognosticate for whether or not you're going to benefit from surgery. And that's the subtype of the disease. You just heard there's an epithelioid subtype, a sarcomatoid, and then cleverly called biphasic or mixed, which has the two types together, and the tumor volume. Those things are probably the biggest prognosticators as far as how successful or how much benefit you can expect from adding surgery to your other treatments. That's not in the staging system. This cancer is highly variable in presentation, so these are both patients I had with mesothelioma, and I would tell you that if that one with the tiny dot is sarcomatoid and the other one is epithelioid, it's a possibility that even though it's earlier stage, although it's later stage by the staging system, the one with the bigger tumor could potentially do better. So you have the different cancers, which the epithelioid or the sarcomatoid can behave differently. These are two different patients. These are two different operations, taking the lung out or saving the lung. Saving the lung, you can have a lot of tumor, a little tumor. So without a highly predictive staging system like we have for lung cancer, you have to assess each one individually. And that's not the case for mesothelioma. The two different operations, you can see the one on the left is where you're saving the lung, you take out all the detectable tumor. The one on the right is where you've taken out the lung, and you can see those white patches where they've reconstructed the sac around the heart and the diaphragm. So those are the two operations that we use to achieve a macroscopic complete resection. And then it gets even more complicated. I said you have to combine other things. So there's chemo or immunotherapy before surgery, after surgery. You can have radiation before or after. There's all sorts of intraoperative treatments. I personally am a fan of that, doing something at the time of surgery. You know there's invisible or microscopic disease remaining. That's an opportunity to attack the cancer one more time. The timing, when you do it, how you combine them, there's absolutely no standardization. And we're talking about a scary, rare cancer, maybe 3,000 cases a year in the United States, maybe 10 to 20% of those patients having surgery. And institutions, there's few places that do a significant volume of this tend to have, we're still working in silos, unfortunately. People are not, so there's no agreement like you would have with lung cancer, breast, that this is what you do, this is what you combine with it. Straightforward, right? So how do you get, life's like this, right? Risk-benefit, which, do the benefits outweigh the risks? And how do you figure out if it's worth it? So I want to mention this. This just came out. This was presented at the World Lung Conference in Singapore just about a month ago. And this is the MARS-2 trial where they randomized patients in the UK to have surgery and chemotherapy versus chemotherapy alone. And what they found was at a median follow-up of 22 months, the chemotherapy group alone saw a survival of about 25 months, an overall survival you just heard about, and surgery was about 19 months. So it was, quote, a negative trial for surgery. At 42 months follow-up, there was no difference. But what I got out of this is that chemo alone, 25 months for patients who were fit enough to be randomized to surgery or not, to me, that's kind of the bar I think you need to cross. There has to be expectation that surgery is going to contribute significantly beyond that. If you're doing surgery, and again, a lot of times you're talking apples and oranges. A patient in the UK with the tumor that they were operating on may be totally different than what you're presenting with or what your family member's presenting with. So these aren't absolutes. But as a general rule, I would say that there has to be expectation from your surgeon and the team that that person is working with, that if they add surgery to systemic therapy, which you should be receiving because that is the standard of care, that the surgery should benefit, that you would see more survival. And I kind of, in my mind, have 25 months as what that would be. So until we have a staging system that includes, and we just redid the staging system, we now have the 9th edition, and we added a measurement of the thickness of the tumor volume on the CT scan and the fissure, but we don't have tumor volume. So we'll probably need AI on that, and we're working on that right now. But until we have that and some molecular markers, et cetera, At this point, I would say selecting patients for surgery is still more art than science to a great degree. And then the last thing, informed consent. You know, your surgeon needs to make sure that you understand exactly, you know, what you're getting into and the risks and benefits. So, you know, what I would say is, you know, who should have this operation? You know, when I'm done, this is, I've showed this slide here before, I just love this. This guy named Raleigh Free. This is at Bonneville Salt Flats. He's driving a Vincent 150 motorcycle. And the way they set the land speed record in Bonneville is there's that line, it's a lake bed, and it's 3 miles long, and it's just a black line, and you get to go one time down, and you turn around, you come back, and they time you. And this guy went down and missed the world record by about a second. And he stripped down, before they could stop him, he stripped down to his Speedo. This is like probably the most famous picture of a motorcycle. He stripped down to his Speedo. Why he kept his helmet on, I don't know. He would have been hamburger if he fell off. But he shed that weight, he spun around, and he set the world speed record. And I got to tell you, you know, when after I consent a patient and they decide that they want to do this, and it's usually, you know, I want to see my granddaughter graduate from high school or something like that, you know, this is kind of the mentality that I think of, that kind of courage. And the other thing I would tell you is that, you know, you need a team to do this. So if you're considering surgery, if family members consider surgery, you need to go where people are working as a team. That's absolutely critical. So I put together some case studies if we want to do that, Maha, however. So, okay, so I'll save those. So this slide, we can bring them up whenever.
So Bill, come on up.
Yeah.
Sure. So my apologies, I was supposed to preempt Dr. Friedberg, but he stole the show at the beginning. So I'm Dan Sterman. I'm from New York University, formerly a partner of Joe's at the University of Pennsylvania. I'm the moderator for the session, and we have about 10 minutes, and we've got an expert panel up here and an expert audience. Many of you may have been considering surgery or have gone through surgery. And so on our panel today, well, behind me, we have Bill Ziegler, a patient who's been through this. We have Dr. Chuong Hoang from the NCI, Joe Friedberg, who you've met, Ibiayi Dagogo-Jack from Harvard, who is a medical oncologist, who'll be talking to us shortly about systemic therapy, and Taylor Ripley from Baylor, who's a thoracic surgeon who performs his operations. So we're open for questions if you have them. We have about 10 minutes or so. If anyone has questions from the audience, or maybe we have comments from the panel, specifically about the issue of surgery. So let me ask the question. I have no skin in the game. I'm a pulmonologist. So is surgery over for pleural mesothelioma? Should we not be doing it at all, period, after the BARS 2 trial?
So my answer is no, but like in my mind, what we got out, so if you're going to have exactly what they were doing there, then I would say no. But if you're doing something different, which most of us are, and I asked Taylor, but I mean, I think if we have a median survival with the same sort of subgroup of patients and we're between 5 and 7 years and they're seeing 19 months, I cannot ethically say that no, that it doesn't make sense to continue. But I do have in my own mind now that the bar that if we're doing a trial and the median survival is 26 months, and it seems like a similar population to what MARS 2 patients were seeing, then I would say no, you shouldn't be doing surgery. But if you're going to be adding, years beyond if surgery has expectation that you can add years beyond what you would see with the systemic therapy alone, then I think it's still reasonable to continue it.
Bill.
So as a patient myself and recalling back 12 years almost now, being out in the audience at a conference similar to this, I couldn't help but think to myself, should I be going through surgery? Do I qualify for surgery? So as a newly diagnosed patient, who should be considering consulting with the surgeon?
Taylor?
Well, I think all the patients should consult with a surgeon. There's really no disadvantage to being seen by a multidisciplinary team. So I think the point is to see a surgeon, see a medical oncologist, see a radiation oncologist, see a team that works as a multidisciplinary team in which we use a tumor board in order to discuss, but seeing a surgeon is a low-risk endeavor. It doesn't mean you have to go to surgery. The vast majority of patients I see do not go to surgery, but I still spend a significant amount of time talking to them. As Dr. Friedberg mentioned, I know when I have patients with mesothelioma on the schedule that I try to block out a much larger percentage of clinic for those patients, because the discussion is just harder and more nuanced than the remainder of the tumors that we manage. Additionally, I never see a patient once and then go to surgery. It's usually a multi-step evaluation and a multi-step discussion before we put surgery on the table. So I would say see the surgeon.
Let's open up to the rest of the panel. So what others think about this?
Yeah, I agree. There's absolutely no reason not to see a surgeon. If only to hear from the surgeon that surgeon's not. I mean, I see patients all the time who got sent in by, a well-intentioned community oncologist said, you can't do surgery for this. And sometimes they're right and sometimes they're not. I think it should be a surgeon who says you're not a candidate.
I'm going to make one comment there. It's not whether you can, it's whether you should. I think it's really important. Those are two it seems very subtle, but these are very technically skilled surgeons. So whether or not they can technically do the operation is not the question. It's whether they should do the operation, right? So Dr. Dagogo-Jack, what do you think?
No, we just chuckled to ourselves that I'm not a skilled surgeon, and so I know that I know this about
Me neither.
myself. Yeah, I'm a medical oncologist. I'm not a surgeon, and so I personally don't like making the decision as to whether or not someone should have surgery because it's not within my expertise. And so we do see people kind of as part of a multidisciplinary evaluation just to make that determination. I think your doctor probably has some sense. One of the key points that was mentioned here is, can the body tolerate surgery, right? So in clinic, sometimes someone will have heart disease or other things that I know that surgery may not be the right thing to do. In that case, I think that I feel comfortable talking about how surgery is not the ideal thing. And I think we don't have wonderful large trials to tell us, even for people going for surgery, whether to do chemo first or treatment before or after. But I am starting to think a little bit more about doing some sort of early therapy before surgery, even for patients that we're considering surgery, because our goal at the end of the day is we want to learn as much about the biology of the cancer as possible to try to figure out if doing more, right, being more aggressive will be beneficial.
Dr. Hoang, should we be doing any surgery outside of clinical trials?
Actually, that's a very thought-provoking question, particularly for this. And actually, I'm going to echo and summarize in just slightly different way everything everybody else has said, which I completely agree with, is that, and particularly where I'm from at NIH, we view all cancers as quite complex. I don't think there is a single cancer out there that is quote-unquote easy, and that is appropriate to be managed by any single medical professional. I think it's a team effort. It is a multimodal intervention and treatment, and therefore requires input from multiple different medical professionals with different viewpoints of expertise. And and I think mesothelioma is sort of a poster child for being very complex. We don't quite understand it, and therefore we don't quite understand how to treat it very well. And I'm pretty sure everybody would agree that even with the team effort, it's still a difficult task to figure out the question about should. And so in a roundabout way to answer your question, I think that there's much more bang for the buck, so to speak, in a trial that we can glean, especially for this particular cancer, which is quite rare. There's not enough cases to go around.
I want to hear from Bill again.
Yeah, before I get to my next question here, I just want to let everybody know that the bereaved celebration of life is getting underway in the committee room. So just to let everybody know and be aware. My next question has to do specifically with newly diagnosed after they do qualify for surgery. Let's say they consult with a surgeon. Where should they be getting their surgery, and why does that matter? Because I was so fortunate to find the Mesothelioma Applied Research Foundation and see great surgeons like yourselves. Could you tell us a little bit about why it's also important to have a great facility behind you?
Yeah, I mean, this is, I think I can speak for the other surgeons on this one. You know, of all the operations we do, I think this one's probably the hardest. It is certainly the most taxing, and there just aren't a lot of them. So it's like anything. I mean, everyone in the audience has something that they do, and you just know that the more of it you do, the better you get at it. And it's just a really challenging cancer. And the other thing is that it's not standardized. It's not standardized. So this is not an operation someone should be doing once every year or two. You know, it is just something where you need to go to a center of excellence that does this type of work and has the medical oncologists, not great surgeons, but great medical oncologists and pulmonologists and radiation oncologists who will be part of the team and are facile with the treatment of mesothelioma. I mean, I think you probably are testament to the fact that that's just so important.
Last couple of comments before we have our next speaker. Any thoughts, Taylor? Any additional thoughts you want to share with the audience?
Sure.
Can I ask one follow-up question after
Sure,
Taylor
please.
here?
Oh, go ahead, Bill.
Well, as a patient going into some of my consults or meetings with my doctors, help me get feedback from you all on what kind of questions I should be asking so I can learn more, so I know what to do next, and I can take that next step.
I think the one thing I would say, right, I think surgery, we have to kind of go away from the concept of thinking of surgery as a single day event, right? I think there's a lot that happens after surgery, and so I think an important thing is, and people ask it, right? So what is the recovery like? How long will I be in the hospital? How can I expect to live after? Like, what am I gaining and what am I giving up by going through this surgery? And then what are the risks, right? And I think we have to be realistic, even when you take someone to surgery, that perhaps the outcome you intend may not be what happens, right? And then so people are as informed as possible, and there's that informed consent that we talked about, and you sign it having had all of the information. And I also think that if you feel after that conversation that you are completely overwhelmed and you want to take a step back and then discuss it with your family and discuss it with loved ones, I think that's okay too, right? It's okay to start by gathering the information. I don't think anyone expects you to make an immediate decision that day.
Last comment?
The only other thing, you know, at the end of the day, you are literally going to be trusting your life to someone while you're asleep for 10 to 14 hours, and then they're going to be taken care of. So you don't have to be drinking buddies, but you definitely want to respect and trust your surgeon. I think if you don't have that feeling, it's probably I would think a non-starter. You need to have that aspect of the relationship has to be intact, and that's not something tangible. That's something only you will be able to sort out.
I'm going to take moderator's privilege here, and we're going to have lots of chance for additional discussion on this topic and others, and hopefully questions from the audience over the course of this morning and then throughout the day today. Our next speaker is Dr. Ibiayi Dagogo-Jack, who is an assistant professor of medicine at Harvard Medical School, a thoracic medical oncologist at Mass General in Boston, Massachusetts, and she'll be talking about systemic therapies for mesothelioma.
Also, panelists, thank you for your answers.
Perfect. Thanks, everyone. So as the sole medical oncologist on the panel, my name is Ibiayi Dagogo-Jack. As mentioned, I'm traveling from Boston, so not too far. And the focus of my talk is really systemic therapies for mesothelioma. And so a couple of key points. This is a short talk, and so I want to make a couple disclaimers. So we're going to largely focus on pleural mesothelioma, but a lot of what we do for peritoneal and other sites of mesothelioma, we borrow from pleural mesothelioma. We're going to focus on treatments that are used in the United States, and I'm not planning to discuss any specific clinical trial therapies because the clinical trials that are available can vary, kind of depending on when you need them. And so you've heard this already, right? And I think it feeds into how we think about systemic therapies as well. There are 3 major subtypes of mesothelioma. Most tumors are epithelioid, but we also have kind of a subset of tumors that are sarcomatoid, and in between we have biphasic tumors that have a little bit of both. When we think about systemic therapy, we tend to lump together biphasic and sarcomatoid. I hope that in the future we won't, as we get better in terms of kind of profiling tumors, identifying biomarkers and other things. But for the sake of conversations about systemic therapy, we tend to think of these as similar in terms of having some sort of a sarcomatoid component. And so that'll come up again as we kind of move through these slides or move through this discussion. And so the beginning of the slide uses the word systemic therapy. When I meet most of my patients with a new diagnosis of mesothelioma, and I use that word, they're like, what is systemic therapy? What are you talking about, right? Because if I go through most of my life having not encountered a diagnosis of cancer, that isn't a term that I toss around all the time. And so I think it's important to distinguish the 2 concepts, right? A local therapy is what you've heard about, right? It's surgery or radiation, and sometimes we talk about a type of treatment called ablation, where you either use kind of radio frequency waves, you use heat or cold to try to kill the tumor. What I'm talking about is systemic therapy, typically given intravenously, so through your veins or sometimes through a pill on a trial, not any of the therapies we're talking about now, that goes throughout or courses throughout your system, your bloodstream, with the hope of getting to all the sites of the tumor. And so traditionally, this has been chemotherapy. More recently, we've started to incorporate immune therapy. And then, of course, there's other kind of clinical trial drugs. And so one of the other things that people kind of ask me when they see me, and one of the medical terms we use a lot, that it isn't something we're born with an understanding of, is immunotherapy, right? So if you're not in the medical field, you may not have encountered immunotherapy before, and so it's a foreign concept. And so so this slide just exists to try to talk about the 2 relevant types of immunotherapy in mesothelioma. And so at the most basic kind of maybe oversimplified way to think about immune therapy is that you have cancer and you have an immune system. For some reason, the immune system can't engage with the cancer. And if we take it back, kind of like maybe many of you traveled here today, right? To get here, you had to pass through security at the airport. We call it checkpoints, right? And you had to show documentation. They had to prove that you were safe to proceed. We have similar checkpoints in our body, and these checkpoints are places where our immune system interacts directly with the tumor or interacts directly with an intermediate, right? We call these antigen-presenting cells. They hold up foreign proteins like a billboard, so your immune system knows exactly what to look for. The ways that the system can break down is if there are certain proteins on this cancer cell or on the tumor cell that tell the immune system that it's not foreign and calm the immune system down so it can't attack it, or if there's a block in the ability of that intermediate cell from presenting kind of the tumor particles so the immune system can recognize it. And so there are 2 flavors of therapies that block this. One is a PD-1, PD-L1 inhibitor. They're drugs like nivolumab or pembrolizumab. Problem here is that the PD-1, PD-L1 prevents the immune cell from recognizing the cancer. So if you block it through an intravenous medicine, so an IV medicine, the immune cell can now recognize the cancer. The CTLA-4 is a little bit harder to explain. The drug that is most relevant in mesothelioma is ipilimumab. Here, the T cells are too tired, right? They're not engaged enough because there's another protein called CTLA-4 that tells them they don't need to be activated to attack the tumor. So in mesothelioma, these 2 particular checkpoints are relevant when we talk about systemic therapy. Another framework that we think about when we talk about systemic therapy is how can we tell if it's working, right? People ask me that. And so if you ever come across any medical literature or something, they use a couple of key terms, right? Response, we look for shrinkage. We're happy with shrinkage, but because mesothelioma can be hard to measure whether or not it's responding, we also like disease control, right? If you can stabilize it for a long period of time, that's good as well. We also use a term called progression-free survival. We tend to think of it as the time between starting treatment and when the cancer grows or someone unfortunately passes away. And then overall survival is just time between starting therapy and passing away. I present this just so it helps us think about the goals of treatment, right? So our goal as medical oncologists, as surgeons, as radiation doctors, et cetera, is to shrink and control the cancer. We want to halt the spread of the cancer for as long as possible, and we want to help our patients live as long as possible, and importantly, with a good quality of life. And so those are our goals for our treatments. Hopefully one day we'll say our goal is always to cure patients, but hopefully one day we'll get to that stage. And so what are the treatments we have available right now? So standard therapies your doctor can write for you if you have a new diagnosis of mesothelioma. So the standard initial chemotherapy is 2 drugs at the same time. This was kind of set as a standard about 2 decades ago. One is called a platinum drug, either carboplatin or cisplatin, and the other one is pemetrexed, sometimes called Alimta. Logistically, both of these are given together as an outpatient in the clinic, and people are not hospitalized when they receive this treatment. It's 1 round or 1 cycle is every 3 weeks. We tend to give it for 4 to 6 rounds. Most people don't continue on the treatment because we haven't had sufficient data to tell us that it's better to continue some sort of maintenance. Rather, we give people a treatment holiday and we monitor the cancer. Some doctors do things differently, so your doctor may have continued it as maintenance. There are some doctors who might add a different chemotherapy to this cocktail. So now 3 drugs called bevacizumab or Avastin. That blocks the blood vessels that the cancer may need for it to survive and for it to traffic or migrate to other sites. That is not approved by the FDA, but there are trials supporting it, so your doctor could write that for you as well. So what can I expect as far as side effects from platinum pemetrexed? The most common side effects are fatigue, nausea, and so your doctor would typically give you anti-nausea pills and give you instructions on how to take them. Diarrhea and constipation, I tend to think of these as being related to the nausea pills, not necessarily related to the treatment itself, the chemo itself. Chemo targets rapidly dividing cells, and so people have lower blood count. As part of this chemo cocktail, people get folic acid and vitamin B12 to help prevent the counts from being too low. Sometimes if the counts are too low too long, your doctor might give you blood transfusions or kind of growth factor boost. You can also get swelling, allergic reactions. Rare, you can have an allergic reaction. So people get steroids when they get the chemo. It's not common to lose your hair completely from this regimen. People can have hair thinning though. And then depending on whether or not you got cisplatin or carboplatin, sometimes you can get nerve pains, some ringing in your ears. Important to mention that to your doctor if you have that. And your kidney function is monitored very closely on treatment. In fact, before each treatment. I think it's important to note that about 1 in 10 people end up stopping treatment due to a side effect completely, but others may need to interrupt it. So higher rate of people needing to interrupt it and a higher rate of people needing to reduce the dose to find the optimal dose for your body. What about immune therapy? So the standard immune therapy regimen is 2 drugs as well, so we call it a doublet of ipilimumab, targeting that CTLA-4 protein, and nivolumab or Opdivo, which targets PD-1. Each round is twice as long as the chemo now, so it's 6 weeks. Again, given IV as an outpatient, you don't need to be hospitalized for this, but a little bit different in that the ipilimumab you get once every 6 weeks, and nivolumab you get 2 or 3 times during that 6 weeks period, depending on what your doctor selects. You usually, unlike chemo where I said you stop after 6 to kind of 18 weeks, so 4 to 6 rounds, here you stop after 2 years if no progression. And the idea being that you've now re-educated your immune system as to what to kind of traffic your body and look for. The side effects of immune therapy are different from chemo, right? So most people don't have that fatigue, the nausea, etc. But when you rev up your immune system to attack a cancer, it can cause inflammation of your organs. It can look a little bit like an autoimmune disease. Most people do not get it, but it's important to recognize that you can get inflammation of the thyroid. Your doctor should monitor this lab test. We tend to look at it every 6 to 12 weeks on treatment. If you have skin toxicity, you can get a rash or itching, diarrhea, if intestinal toxicity. Rarely, people can get lung inflammation that causes a cough or shortness of breath, adrenal gland inflammation, kidney inflammation, or brain inflammation. These are all very rare. More commonly, you can have some achiness of your joints. I think nothing is too small to bring up to your doctor because it could be related to the immune therapy, and it does respond to steroids as far as the treatment. Here, 1 in 5 people end up having to stop the treatment because of a side effect. I think we should be reassured by the fact that we have lots of data now that says if you stop it because you have a side effect, it can still continue to work in your body because it lasts a long time. And so sometimes, as a doctor, I might have some concerns about giving someone 2 immunotherapies at the same time. We know that adding that ipilimumab increases some of the toxicities, and so sometimes we might give you 1 immune therapy by itself. I'll tell you right now that that's not approved as a single agent or by itself, but there's lots of data supporting it, and so most insurance companies will allow it. And the reason to do this is that it may be more tolerable if you do it this way. And in that case, we tend to pick the drug like nivolumab or Keytruda or pembrolizumab in that setting. So how do we choose between these two, right? Do we have data that tell us one is better than the other for a given patient? And we do. We have a big kind of phase 3 study that gave half the people the immune therapy 2 treatments at once, and the other half the chemotherapy 2 treatments at once. On balance, the immune therapy, people did better when they had the immune therapy, but I think it's a little more nuanced, and I'll discuss that in the next slide. But going back to those metrics that we talked about, right? Response, right? So the response was comparable with the 2 treatments, but the amount of people who had their cancer halted for a longer period of time and the amount of people who lived longer, right, was better with the immune therapy. And so most people who are newly diagnosed now end up getting immune therapy first. But I mentioned it's a little bit more nuanced, right? And that's the reason I mentioned epithelioid and non-epithelioid at the beginning. We've known for a while that unfortunately, when you have sarcomatoid components to your tumor, it doesn't respond as well to that chemotherapy cocktail that I talked about, that platinum pemetrexed. And for that reason, immunotherapy, when you get immunotherapy, on balance, people do a lot better, they stand to do a lot better than if they were to get chemo. And so if you have a newly diagnosed non-epithelioid mesothelioma, most doctors would give you immune therapy first. For epithelioid, there can still be tumors that benefit from chemotherapy and have very durable responses to chemotherapy. And so here it's more of a conversation. If you have an autoimmune disease, if there's some reason that your doctor thinks that you might do better with chemo, they might start with chemotherapy. And so I don't want to make it seem like those are the only treatments available, right? So there are other medications that your doctor can write for you if the ipilimumab, nivolumab stop working or the platinum pemetrexed stop working. There are additional chemos. One is called vinorelbine, the other one called gemcitabine. They're usually given weekly or every other week. Your doctor could talk to you about that. But this is the time point where we also start thinking about clinical trials and kind of talking to other physicians about clinical trials. Clinical trials can be IV therapies or they can be pill therapies. They can be available for all people with mesothelioma, or they might be available only if your mesothelioma has a specific change in it. And so your doctor might talk to you about some tumor testing at this point. And so key points before we kind of open it up to questions. I think it's important to note that we have 2 main types of treatment that are approved for mesothelioma, systemic treatments, immunotherapy and chemotherapy. Most people, for each of these categories, will get 2 treatments at the same time. So 2 immune therapies or 2 chemotherapies. It really is a conversation about which one to start with, but for non-epithelioid mesothelioma, I tell you most of the doctors in the field feel that immunotherapy should be given first. If you have any side effects, let your doctor know. Sometimes they can progress to become more significant if we don't address them early. Most of these are quite addressable. And I think it's important to note that even after some of these approved therapies run out, there are other therapies your doctors can give you, but it's also important to think about clinical trials and start those conversations early. And so with that, I will wrap up and turn it back to our moderator.
Thank you so much for that fantastic presentation. So we have a few minutes for questions, and we have both our panel and we have the audience. Yes, we have a question from the audience over here, sir.
Wait, speak in the microphone because we are on the live stream and they can't hear you.
Don't be shy.
Okay, thank
I know
you.
the front tables are kind of empty, but don't be shy about questions.
Yeah, I just have a question about the pemetrexed or the immunotherapy. If you've been on that and then you stop because you normally stop after a while, can you go back to those after a while and see if maybe it might help to go back to them if they were successful and they did keep you well enough? Is there any good reason to go back to them, or is it no longer going to be beneficial?
I think that's
After chemo, yeah.
Exactly. I think that's a very good question, right? So we tend to stop chemo before we have any signs that it stopped working, right? Because we want to give people kind of quality of life. And so if while monitoring the off of treatment, you see the cancer start to grow again, we tend to think about, as a 6-month, as a type of cut point where it might be beneficial to re-challenge or retreat with the same chemo. What I mean by that is that if the cancer starts to show signs of growing again, within 6 months of stopping the chemotherapy, it's unlikely that going back to the exact same thing is going to be beneficial. And so we want to pick something else at that point. But if it's 6 months out, 9 months out, 12 months out, that means that your cancer was halted by that chemotherapy, and re-challenge or reintroducing that chemotherapy at the sign of growth is a good idea. Similarly with immune therapy, right, we stop at about 2 years for most people. But interestingly with immunotherapy, if the cancer hasn't changed at all, like it's stable and you've been on treatment for 2 years, many people may not need additional therapy. But if you do see the cancer start to grow again, it's a good sign that the cancer took 2 years, it took more than 2 years to start to grow again. And so my colleagues and I would reintroduce the immunotherapy, provided that your body handled it well, right? If we stopped it because you had inflammation of an organ that was severe enough that we felt uncomfortable, all of us, right? You as a patient, me as a physician felt uncomfortable treating you. We find sometimes that, people have done the data and done the studies in kind of other types of tumors, that if you give the immune therapy again, the inflammation just comes back. And so we're a little hesitant. We might do one immune therapy instead of the 2, but we're a little bit hesitant. We need a compelling enough reason to give it, because we don't, at the top of everything, all of our goals is to not cause any harm.
We have time for one more question here.
And this may be part of this novel therapy part of the day, but I had heard about this thing called Optune Lua being used along with chemo or immunotherapy. Have you heard of that? I'm over here.
Oh, okay, sorry.
Sorry.
I was squinting, sorry about that. Yeah, so Optune Lua is interesting, right? So I talked about systemic therapy. So Optune Lua is kind of a local/systemic therapy. For those who are not familiar with it, it's basically a device that you wear, right? It has these, basically, if you've ever seen people get like an EKG or unfortunately like CPR compression you've seen on TV, those sticky pads that they put on. So they basically put electrical current to the tumor, and it's hard to explain, but all cancers need a particular electrical frequency for them to grow and divide, right? And this company's concept is that we're going to break that up, right? We're going to change the electrical charge so the cancer cell can't divide, and we're going to do it in a way that's specific to the cancer cell and not the rest of your normal cells. But the way you do it is you deliver it locally. So you have to wear this little pack, and you have to ideally wear it for at least kind of 18 hours out of 24 hours a day. And so when they did that study, they took people with platinum pemetrexed, the chemo I talked about. We've not tested it with immunotherapy and mesothelioma, and added the little pack, right, the device to it. And they didn't compare it to people who had received chemo by itself, right? So it was just a single arm study. And at face value, the survival when you added that pack looked a little bit better than 20 years ago, right? 15, 20 years ago, when people first did that study that showed that 2 chemos was better than 1. For that reason, because we all want more treatments for mesothelioma, the FDA approved it, right, as something that people can have access to. So I say that all to say that it is an available therapy, but right now in the field, we're not sure if it's better than the standard therapy, and it can take a bit out of your body to have to wear that device for 18 hours or so, but it is worth talking to your doctor about if you're interested in it.
So please hold any additional questions. I do want to give the rest of the panel a chance to comment. From a surgical perspective, how do you look at systemic therapy for mesothelioma in terms of best combinations for what you may have to offer? Taylor?
Thank you. So what we know with surgery is all the surgical trials and the survival associated with those have been combined with additional therapy. And mostly over the last 20 to 30 years, that's been in chemotherapy. And so we always recommend that surgery is given with chemotherapy. However, what we also know is that patients who received ipilimumab and nivolumab, or immune-based therapies, did reasonably well on the recent Checkmate 743 trial, which we just discussed, that showed better survival compared to at least the historical regimens from 20 years ago. But what we don't know is, do we combine surgery with immunotherapy? So right now, many of us are actually taking that strategy of treating patients with immunotherapy followed by surgery based on clinical trials that are opening at multiple institutions around the country. So I think that our next biggest question is going to be, are the outcomes that we've seen better with surgery combined with immunotherapy as compared to our prior approaches?
Dr. Hoang?
In general, to directly address your question, I agree with what Taylor said too, but I view these complex cancers as an opportunity to kind of throw the kitchen sink at this thing. So in general, my general viewpoint is I prefer systemic treatment up front, and if you're going to have any chance to alter the tumor prior to surgery, I think doing it before surgery in general is a good approach.
So that, I think that's a reasonable approach sometimes, but what we know from the Imprint study, which was chemotherapy followed by surgery followed by radiotherapy, the survivors were similar to what we had seen in chemotherapy and surgery, but of over a third, about 36% of the patients who didn't respond to systemic therapy progressed before surgery. So that led to a change where the new Imprint study was recommended surgery followed by chemotherapy. Whichever strategy is correct is still, I believe, an unknown. And so if a tumor is surgically resectable and we believe that surgery is the right direction to go, do we do it before or after chemotherapy is still uncertain.
I would provide a counterpoint. I think that my bias is to do the only thing I'm 100% committed to is that the patient receives a systemic therapy. And this is such, with safety in mind, my bias has been to do the chemotherapy or systemic therapy after surgery, because if you have a reaction, one of those reactions that you talked about, you may have gone from a safe surgical candidate to an unsafe surgical candidate. You now have colitis, or you now have some kidney damage. Now your window as a safe candidate may have passed. That said, I am completely, I think these should all be done under a clinical trial, and I think we need to answer that, and we need to be working together to kind of pool those. But given my druthers, I would do the systemic. We do in thoracic surgery, we'll do, some patients will have like a lung cancer that's very central, and you say, geez, if we could shrink that down some, we might be able to save part of the lung, whereas if we operate on them now, we won't be able to, so-called downstaging. This doesn't make the surgery any easier, giving the system. It's not like shrinking the cancer down makes the operation any easier, so it doesn't affect that technical aspect of it for me. So with an eye towards safety, my personal bias, but again, I'm open to doing preoperative treatments, would be to do the systemic therapy afterwards.
We'll come back to this conversation and more questions from the audience in a minute. I just want to take a few minutes and take you through a rapid-fire overview of the active clinical trials in mesothelioma. And just to say two things. One is, I think my bias, especially as someone who doesn't really have a skin in the game, I'm not a radiation oncologist, I'm not a medical oncologist, nor am I a surgeon. One might wonder why I'm here then, but I do sometimes myself. But it's really important for me to think about whether a patient, a priori, right up front, should be considered for a clinical trial. And the second thing is, going back to what I just said about my role, I'm a pulmonologist, a lung specialist. I'm the person who might be the first person to see a patient with mesothelioma before we know that they have mesothelioma. I may see you for shortness of breath or chest discomfort or persistent cough. I may be the person as an interventional pulmonologist who does the biopsy that makes the diagnosis of mesothelioma, and I may be the one that has that first conversation with you before you're referred to a center of excellence to see an expert surgeon or an expert thoracic medical oncologist. And so I'm not that dissimilar from you in the audience, the patients and the loved ones, in trying to decide how to navigate what to do. Because again, I'm not an expert in therapy. I'm knowledgeable about diagnosis and staging, and a little bit knowledgeable of some of the experimental therapies. So when I think about counseling a patient about clinical trials, and I go through the panoply, there are so many, it's almost impossible to really sort out what I should be talking to the patient about, even though that ultimately would be a conversation with, for example, the medical oncologist. So there are surgical trials, and you heard about what neoadjuvant, this is a hot term in all of oncology, which is giving treatment in advance of surgery. I will say that this appears to be revolutionary in lung cancer. and there's some extrapolation to mesothelioma that this may also be revolutionary in mesothelioma, but we need more data. Radiation therapy, obviously, is something that's really important. We don't know how it fits in with the other trials. Immunotherapy trials, they're both systemic, and then there may be developing intratumoral studies or even combinations where you can deliver the immunotherapies directly to the site of the cancer, potentially in combination with giving things intravenously, again, in an experimental fashion. Chemotherapy studies, interestingly, and I'll show this in a second, as you go through the listings of clinical trials, there aren't that many studying what we would call classical chemotherapy, these drugs that kill tumor cells through so-called cytotoxic mechanisms. More of what you would see, and I'll show you a couple of examples, are so-called targeted therapies, which aren't classic cytotoxics, but rather agents given systemically which target specific abnormalities on the tumor cells themselves. Cell therapy is a very hot area. We have many of the world's experts who are actually here today, will be speaking during the course of today, and hopefully you'll have a chance to speak with them. And you may have heard of what are called CAR T cells, or chimeric antigen receptor modified T cells. And also, not talked about today necessarily, but it's another type of cellular therapy called TIL therapy, where literally the lymphocytes, the white blood cells that infiltrate the tumor, can be harvested from the tumor, grown outside the body, and then re-administered to the patient, sometimes modified. So two different approaches to using your own white blood cells. Some have been pre-educated, some have to be educated afterwards to treat. And then the other thing you realize, and for those of you who have peritoneal mesothelioma or loved ones of those with peritoneal disease, is that the preponderance of clinical trials that you'll find are for pleural mesothelioma. And so there are relatively few trials for peritoneal, and if you have even rarer subtypes, pericardial mesothelioma or mesothelioma of the scrotum in males called the tunica vaginalis, there are no trials designated for those types of mesotheliomas that you'll find in the medical literature. And then when you're thinking about clinical trials, it also can be confusing, and you heard this from Ali earlier, about the different phases of a clinical trial. There are actually 5 different phases, but I'm going to focus on phase 1, phase 2, phase 3. Remember that a phase 1 essentially is for the first and foremost, a safety trial. This is a drug or a drug combination that hasn't been used before. Is this safe and feasible to be used in human beings? Phase 2 means that you've probably done a phase 1 study, and you've shown that it's safe and feasible. Now, does this appear to work? And how it works, you heard from Dr. Dagogo-Jack about how we analyze that. And then phase 3, we would compare that experimental therapy to a standard of care. So those are the main 3 phases. And then how do I go through this? Well, this website is something that you should all have embedded in your phones, on your notebooks, anywhere, because this is where I go. And this is where I got the studies that we're going to be talking about in the next few minutes. Clinicaltrials.gov is something that the National Institutes of Health has as a resource for all of you. All of the clinical trials that I'll be talking about are listed there. They list whether these are actively enrolling, whether they've completed enrollment, whether they've been shut down, and why. They also have to update data on the number of patients enrolled, the outcomes that have been reported to date, and the complications that have been reported. They list the principal investigator. They have her or his email address. You can reach directly out to Dr. Dagogo-Jack and get her information about a clinical trial she's running. And they even have all the sites, so you can find out if it's a 20-site study, is there a site near where you live? So I am not going to go into any great detail, just to show that I went through clinicaltrials.gov a couple days ago. And I went through literally 130 clinical trials. I'm just going to give you a quick overview, a smattering of some of the ones that I found. And actually, Dr. Ripley and I were discussing some of these today. So one of the key questions that we all face is surgery appropriate? And is surgery appropriate in the new era where we have immunotherapy? And by the way, the MARS-2 trial, unfortunately, did not answer that question. So there are a number of trials, in fact, there are probably 7 or 8 across the country that are looking at combinations of chemotherapy and immunotherapy, or immunotherapy alone in combination with surgery, and certain unique aspects of doing the surgery to try to see if this is going to be efficacious. Now, as you see, 2 of these are phase 1, 1 is a phase 1/2, so none of these is a definitive study that's going to get us to the answer that we need. But really important questions, and going back to what Dr. Hoang said, a lot of really interesting biology that we're going to learn from these studies, because a lot of them have a lot of correlates from taking blood and looking at the tumor cells that we would explant at the time of surgery. And then there's some really interesting trials of combinations of radiation therapy and surgery, in which radiation therapy may not be used as you understand radiation therapy, but being used actually as a way of killing tumor cells and creating an internal vaccine where literally you're vaccinating the patient against their own tumor and then removing the tumor. So this first started about a decade ago at the University of Toronto. Professor Marc D. Perot there and colleagues led a trial called the SMART study, where literally they gave really high dose radiation and then removed the entire lung, an extrapleural pneumonectomy, and showed the patients did really well. And then they've also moved on to Toronto to what's called the SMARTest study, where they're using lower dose radiation in combination with other therapies to see if surgery outcomes can be better by using this upfront radiation therapy. And others are looking at combinations of radiation, chemotherapy, and surgery to see if outcomes can be better. So radiation does play a role, but in a unique way where radiation almost is an immunotherapy in some of these patients. And then people are looking at radiation in combination with other immunotherapies. So these are two trials, one for Memorial Sloan Kettering, one for the Mayo Clinic. One where they're using, we heard about the imprint study from Dr. Ripley, where they're using a type of radiation therapy that can encompass the entire pleural surface in a patient with pleural mesothelioma, and combining that with pembrolizumab. Again, this is a phase 1 study. Again, safety and feasibility. So it's going to just give us some early information about whether this is reasonable and safe to do. And then the group at the Mayo Clinic in Rochester is doing what's called SBRT. You might have heard this as CyberKnife, for example. It's a way of targeting specific areas, almost like a postage stamp focused area of radiation, and seeing if you can do that in combination with immunotherapy, whether that would actually enhance the benefits of immunotherapy alone. Again, an early phase trial will give us some interesting information about safety and feasibility and maybe the biological activity, but it's not a definitive study that this should become a standard of care. I will say that the first trial up here, unfortunately, in my search of 124 clinical trials, is, I think, and I can stand corrected, the only phase 3 randomized controlled trial, which is international, in mesothelioma that may be leading to a new standard of care. It's called the DREAMER trial, and it's a beautifully designed study, originated in Australia, now an international study across the world, multiple centers, in which we're comparing chemotherapy and immunotherapy to chemotherapy or combination immunotherapy. And hopefully will give us an answer as to whether chemotherapy and immunotherapy for patients who aren't surgical candidates, and this is an interesting question about whether we should be extending this to those who are surgical candidates, is going to be a new standard of care. A phase 3 trial. We need more of these. We don't have enough. And then the other two interesting trials, one at the NCI with a good friend and colleague, Dr. Rafid Hassan, taking a novel immunotherapy, injecting directly into the tumor in combination with an immunotherapy that you heard about from Dr. Dagogo-Jack, ipilimumab, which is given intravenously. Again, a phase 1 study, a feasibility study, and then a really interesting study at Mount Sinai, where before surgery, they're injecting a immunotherapy directly into the tumor, again, to see if they can make the patient have a vaccine-like effect, use the patient's own tumor as a vaccine prior to removing the tumor. Again, this is not an exhaustive list. This is just examples of what you can find in the literature. And then I put chemotherapy trials in quotation marks because, again, ironically, as we think about classical chemotherapy drugs, you heard about pemetrexed, cisplatin, carboplatin. If you look 20 years ago, you would have found combinations of different chemotherapy drugs listed. You don't see those as active trials currently. So these are two unique trials, one at MD Anderson led by Ann Tsao. Again, this is a phase 2 study, and one at the University of Chicago led by Hetty Kindler, another phase 2 study. But these are drugs, which are not classic cytotoxic chemotherapy drugs, which are targeting specific aspects of the tumor. One, a specific protein on the tumor cell, and the other, a specific mutation in the tumor's DNA. So again, these are probably closer to what we call targeted therapies from the world of lung cancer, which is looking at a specific abnormality in a tumor cell, taking a specific treatment that is targeted against that abnormality and trying to get good outcomes for the patient. I mentioned cell therapies, the variety of cell therapies that you'll hear about later today and some of the novel treatments. I think these are really exciting. And again, a lot of them have to do with taking your white blood cells out of your body, genetically modifying the receptor on the white blood cell, the T cell, that binds to other cells in the body, specifically we're hoping tumor cells. And there are unique ways, for example, Sloan Kettering is combining a receptor for an antigen called mesothelin, which is on mesothelioma as well as other cancers, with a way of actually building a checkpoint inhibitor directly into the CAR T cell, which is, I think, a brilliant approach. And there's some other approaches that are being studied now at Penn, my former institution, which I think are very early phase, and we hope to learn more about these cellular therapies. But again, these are not ready for standard of care. These are still early phase 1 trials, really safety and feasibility. And then in peritoneal mesothelioma, unfortunately, we have relatively few studies. Again, looking through the 124 active clinical trials for mesothelioma on clinicaltrials.gov, these were, I think, only 2 that were specifically for peritoneal. There are others that may include peritoneal, but they look at combinations of chemotherapy given into the peritoneal cavity and systemically, adding immunotherapy, still looking for that best combination. But remember that there's maybe 1/10 the number of peritoneal patients as there are pleural patients. And so it's hard to enroll patients into clinical trials, and it's hard to have a lot of clinical trials in this disease. So I try to give you a very rapid overview of clinical trials in mesothelioma. This is my way, again, of what I do when I see a patient, and a patient has a specific stage of the disease, subtype of the disease, other clinical problems. This is the kind of search that I go through. Hopefully you too will utilize clinicaltrials.gov, which is a remarkable resource to be able to get some of this information. And we only have a couple minutes, so I'm going to open up to the panel and say, what do you think about clinical trials? Should this be the first thing that we discuss with a patient, or should we be talking about standard of care first and clinical trials only if patients don't do well?
I mean, I would favor with this particular cancer that clinical trials should always be encouraged, personally. You know, until we're doing much better, I think that clinical, you know, as long as there's expectation the patient's going to get benefit, I ideally would think every patient with mesothelioma would be on the clinical trial.
No, I would agree. I think it's important to be seen for a clinical trial early on. I think most of our clinical trials are focused kind of later line, so after traditional therapies. But I think that one thing to point out with the DREAMER study, unfortunately it closed like 3 weeks ago because they couldn't get enough people on it. And I think that it really is like education about like the provider community. It's easy to start a therapy off the bat, but a bit hard. We find it a bit more challenging to enroll to first line, so your first treatment trial, because most people see their doctor in the community, right? Not perhaps at the centers that have the clinical trials. So I think it's important for us to start to think about clinical trials from the beginning for that reason, to answer these key questions.
If no one else has a comment, my last comment would be that for this particular disease, I think with the complex biology and the complex treatment, I don't think anybody single-handedly can claim that there is a standard approach. And so by definition, I would echo what Dr. Friedberg said initially, is that they should all come and get considered into a trial in one way or another, either early, late, or at some point. But I don't think that this is a type of cancer that is just routinely treated out in the community and then it disappears.
Can I ask two? Yeah.
Can I ask the two non-surgeons here, what are benefits to the patient beyond, you know, I mean, we're benefiting future patients with a clinical trial. That's that's the real goal at some level. We're trying to learn more, but are there immediate benefits to a patient being in a clinical trial?
You're taking both.
You get 2 microphones if you're in a clinical trial.
Yeah. I mean, I think that it's important that, you know, we have to point out from the get-go, right, that we don't know. Clinical trials, for the most part, are exploring investigational therapies, right? So we don't know, especially phase 1, right? So we don't know how well it's going to work. There may be some aspect of your tumor that makes your doctor think, usually based on laboratory studies, that makes your doctor think that maybe your cancer might benefit, right? But the other thing I would point out, kind of along holding these 2 things true, is that the therapies that we talked about started as clinical trials, right? The only way to get across the finish line with our current regulatory climate is to start as a clinical trial and make your way through phase 1, phase 2, phase 3. And so for that reason, I don't think that the absence of your doctor being able to tell you this will directly benefit you right now is necessarily a deterrent for the clinical trial. I think that you have to have a very involved discussion of the potential side effects, how far along the trial is, what it would take for you, right? Do you have to travel 10 hours for this trial? Does it make sense within your journey at that point?
Let's open to the questions to the audience. Are there any questions to the audience regarding the clinical trials for myself or any of the panelists?
We have a very quiet audience today.
Oh, there's a question in the back. Thank you so much for the question. Hopefully you're not a plant. I did not talk to you beforehand.
I actually have 2 questions.
Great, thank you.
One is about the chemo immunotherapy combo and what you're seeing. And the second is about CAR T and TIL and how pervasive is that? I saw that those trials are happening at 2 different hospitals. And do you have any information about those?
For the chemo-immuno, it is the standard of care across a bunch of different diseases, including kind of our neighbor in the chest, so the lung cancer, and so the rationale for borrowing from those standards is the reason to do those trials. What was presented was a chemo plus an immune therapy called durvalumab, but there's other ones being conducted kind of across the US, across the world, looking at other combinations. This was a phase 3 study based on phase 2. Phase 2 means they already know how safe, they already know what doses to use. There was one conducted in Australia, one conducted in the US, that showed that people tolerated it just as much as we expect from immunotherapy, right? So those side effects I talked about, the chemo side effects I talked about, there were no brand new side effects, and there wasn't any additive side effects. And there was a hint based on a single arm design, meaning they didn't compare to anything, that people might do better with that than the historical standard of chemo by itself. At the beginning, I mentioned that there's many different immune therapy combination trials because I wanted to kind of leave a little room to mention a different trial that we saw at one of our conferences this year, which was looking at a different immunotherapy called pembrolizumab, right, Keytruda, in combination with chemo, and there they directly compared it to standard of care chemo. People live longer when they got the chemo plus immunotherapy. That has not made its way to our approvals yet, but that's the reason people are excited about these combinations of chemo plus immune therapy. So I would not be discouraged that that one has closed early. There's multiple ongoing ones, and we hope as providers that maybe one of these will stick. There are some intriguing things that we see, but all of us are working hard to try to figure out who is it that would benefit from maybe getting 3 drugs, right? 2 chemos, 1 immune, or 2 immunes versus 2 chemos. And we still, as a field, have our work cut out to try to sort through that.
We have the question about CAR Ts. Dr. Hoang, you're at the NCI. We have a lot of TIL therapies and others going on to the NCI. Do you want to make a comment about the current status from your perspective of the status of cellular therapies?
Well, in particular to TIL, we do a broad, ongoing, long-term intervention trials with TIL, but notably, we don't do it for mesothelioma. So I'm very familiar with the TIL program under Dr. Rosenberg's guidance, and they've tried multiple different types of solid tumors, but this is one of the ones that is not currently being pursued, and I'm not sure why, although that's a good patient question, and I'm sure if you if you make a referral to the NCI, we'll ask Dr. Rosenberg together, but there are considerations too in terms of being able to, this is an unusual tumor, unlike the other ones where part of the TIL treatment is that you have to have visible tumor left, or at least in the current incarnation, you have to have visible tumor left behind so that they can monitor the effects of the TIL treatment itself. So this is, I'm not sure how we would work out those logistics, at least for mesothelioma. It's a little weird tumor because it doesn't manifest in wide distribution. It's predominantly localized to one chest or the other in its most common form.
We're going to shift gears a little bit, and we'll have time for other questions and comments afterwards.
Can I also just say one thing?
Go ahead, Maya.
We do have breaks together with our clinicians and scientists, and that was on purpose. Please don't be shy. Feel free to go up to them because that is the entire point of this conference. So we can do your question. Can we do it after the presentation? Thank you.
We'll do a couple quick case presentations. So these will also be forums as we discuss these cases for more questions, and so you can incorporate your questions as we present these cases. So this literally is a patient that I saw Tuesday, and from a pulmonologist perspective is both an interesting case presentation, but also unfortunately an all too common case presentation. So this is a very nice 71-year-old gentleman, originally from Croatia, emigrated about 50 years ago to the United States, who works in the construction industry. Former smoker, just for 7 years. He quit almost 50 years ago. And as I mentioned, he had significant occupational asbestos exposure history. So starting in 2020, he presented to his primary care physician with episodes of pleurisy on the right side. Pleuritic chest pain, pain that occurred when he took a deep breath, and he was found to have fluid which was accumulating in his chest. So this went on for a year, or over a year, and finally he ended up in the emergency room. And in the emergency room, he went in, and you can see on the top left-hand side, you'll see what's called an axial section of a chest CT scan. There's a cross-section through the chest at the level of the heart, which is in the center. And on the right-hand side, it's actually your left, but his right, you'll see some grayish fluid, which is surrounding the right lung. This was felt to be pneumonia with what's called parapneumatic effusion, which is the inflammation of having an infection in the lung causing an accumulation of fluid. So they drained the fluid from his chest in the emergency room, sent him home on antibiotics, sent the fluid off for analysis, and did not make a diagnosis, neither of infection nor of cancer. And at the bottom, you can see the repeat CT scan that he had just a couple of months later. And as you look at his right-hand side, which is your left, you'll see an area at the very bottom of the right lung, this little area, arcuate area of density. This is just what's called atelectasis, or lung that's not fully aerated, left behind from when the fluid was there. And so he went on for several more months and had more chest discomfort and was found to have more fluid, but not a lot, not enough for another drainage procedure on a chest x-ray done. So this is now almost 2 years into having recurrent right-sided chest pain, presenting to doctors, presenting to an emergency room. And finally, he has a chest CT scan done now almost 3 years after initially developing symptoms. This chest CT scan now shows not just fluid, actually minimal fluid, but shows thickening of the right-sided pleura and adenopathy, which means enlargement of lymph nodes in the center of the chest and on the side of the chest near where the thickening was. And the concern on the read of this chest CT scan now 3 years later after presentation was for a possible mesothelioma. They then did a PET CT scan, which is a combination of an anatomic study and a metabolic study, which allows you to look at both the structure of the organs of the body, in this case, the structure of the thickness of the lining of the lung, and the metabolic activity. And they saw that the metabolic activity was elevated in that lining as well as in some of the lymph nodes. And then at a community hospital, he underwent a procedure called a bronchoscopy, which is putting a scope with a video chip at the end through the mouth. Some of these scopes have ultrasounds built into them, and they could then go down and sample some of those enlarged lymph nodes that were seen on the CAT scan and on the PET CT scan. And unfortunately, the biopsies were, again, non-diagnostic. They saw what are called atypical cells, but they were not enough for the pathologist to make the diagnosis of any cancer, let alone mesothelioma. At this point, now 3 years later, he was appropriately referred to a community thoracic surgeon who performed what's called a video-assisted thoracic surgery, which is a way of using small incision surgery, cameras inside the chest, to try to visualize the chest cavity and take biopsies of the thickened lining. And finally now, in March 9th of 2023, 3 years after initial symptoms, an egregious delay, honestly, to make the diagnosis of mesothelioma. And have you heard from Dr. Dagogo-Jack and others, there's different subtypes. This subtype was the most common, called epithelioid. At this point, he'd been in a community hospital, and he was then referred to our cancer center at New York University in New York City. And our surgeons are experts in robotic thoracic surgery, and he was interested in, not that there's actually a wide range of published experience in mesothelioma, but he was referred for consideration of robotic surgery. Our surgeons looked at the results from before, and to their credit, we presented the case at our multidisciplinary tumor board, and the decision was to repeat the bronchoscopy because of the findings on the CT scan, and specifically the PET CT scan that showed increased activity in the lymph nodes. We did not believe the non-diagnostic results from the outside hospital. So our interventional pulmonary group went back and repeated this endobronchial ultrasound-guided biopsy, and all the lymph node sample showed evidence of epithelioid mesothelioma. So now we have a patient who has had a pleural biopsy done by a surgeon confirming mesothelioma, and we have multiple lymph nodes that are involved with mesothelioma. And so he was started on treatment by one of our medical oncologists, who's an excellent thoracic medical oncologist, but not a mesothelioma expert, with the combination that you heard from Dr. Dagogo-Jack, pemetrexed, Orlimta, and cisplatin. And he tolerated the treatment quite well. And our oncologist repeated the PET CT scan after 2 cycles of chemotherapy. And the patient's disease appeared to be stable, both in terms of the thickness of the disease as well as the metabolic activity. And the treatment plan, the treatment was going well. He had no adverse effects. The initial plan by our oncologist was to complete about 3 to 4 cycles and then have the surgeon that originally saw the patient at our cancer center go ahead and do the surgical resection. And then the patient saw me. And then we were talking about what else could be offered for this patient if surgery were not going to be an option at this time, because the patient wasn't convinced this is what he wanted to do. So based upon the medical literature, there were a number of options that were discussed with myself and the thoracic medical oncologist together with the patient. We could add bevacizumab, which is a so-called anti-angiogenesis therapy, which in a large randomized study in France, when added to chemotherapy, showed some benefit for the patient. We could, based upon the study that was recently presented at the American Society of Clinical Oncology, again mentioned by Dr. Dagogo-Jack, we could add pembrolizumab to his regimen. We could consider, for the question of the audience, adding tumor-treating fields to the treatment. And if the disease were progression, there is data from the confirmed study from Dr. Dean Fennell and others around the world that at that point, single-agent immunotherapy with nivolumab might be appropriate. And then I was asked, as someone who does know something about mesothelioma, whether this patient should go on to surgery. And I had to say that at that time, given the extent of nodal involvement at baseline, despite the fact that he had done well with therapy, that I was not thrilled, and we'll hear more from the panel what their thoughts are, about going ahead with a major cytoreductive surgery in this patient with multiple nodes involved, despite the fact that he appeared to be doing well with therapy. So what do pulmonologists do? We order pulmonary function tests. I thought this would just be fun because we rarely show pulmonary function tests. at a mesothelioma conference. It is interesting that when you measure lung function, because mesothelioma is often pleural mesothelioma is a circumferential disease that surrounds the lung, you can actually use, and some studies have used, one of the measures called vital capacity as a response measurement to see where people are responding to systemic therapy. So the other thing that's important to do if you're taking a patient to surgery is to have these as baseline measures so that you can compare afterwards, because part of the quality of life measure will be to see whether or not lung function is impaired. So the patient continued to tolerate the treatment well, minimal side effects, did very well, no shortness of breath, continued to have evidence of a clinical response, although not dramatic, and his PFTs were normal, and certainly, if he was going to go ahead with surgery, were more than adequate at that time. So based upon the initial discussions with the medical oncologist, while waiting for the decision about surgery, he had pembrolizumab added to his regimen. So he had 2 additional cycles of pemetrexed, carboplatin, and pembrolizumab, and then has been on maintenance therapy with pemetrexed and pembrolizumab since that time with an excellent performance status, and with a repeat PET-CT scan just done last week, which showed continued decrease in thickness of the pleura, decreased metabolic activity both in the pleura and in the lymph nodes. And then we had just come back from the World Conference of Lung Cancer, where we had heard the MARS-2 trial results, and at this point, we decided to defer further intervention, and so surgical intervention, I should say, and he is going to continue on his current maintenance therapy. So I open to the panel. What should be done next? Should he go ahead and have surgery? Should we have done surgery already? Dr. Dagogo-Jack, did we do the right thing by adding pembrolizumab to the regimen, which is not currently standard of care? What do people think about this entire presentation?
Well, I'll start. So it's an incredibly interesting case, and I would tell you that, we've talked about the deficits in the staging system for mesothelioma right now compared to, at least with respect to surgery, compared to other cancers that we treat, where we know the stage is this, you're going to benefit. And to some degree, I would almost say that each treatment that you do, surgery-based treatment, almost needs its own kind of staging system. And so looking at our last 60 patients, which we presented at World Lung, the lymph nodes did not meet statistical significance. There was a trend toward not doing as well if you had lymph nodes involved. The big one was tumor volume. If your tumor volume was over 500 milliliters, then you would be better off not having surgery. And then the major one was the subtype of the disease. So this patient has low volume disease, and I would just kind of eyeball it. I haven't seen the rest of it, but I would guess that that's going to turn out to be 200-300 mils. It's not a lot of cancer, it doesn't look like. And it's epithelioid subtype. I would personally have the discussion with him, and he's already declared that he has a more indolent form of mesothelioma than most, although it appears to be accelerating now. But 3 years without doing anything for the most part, the tumor's kind of telling you that, maybe this is a window of opportunity. I don't know. So I would personally have the discussion with him saying that lymph nodes aren't good, but for us, in our hands, it would not be an exclusion criteria. But I conclude every one of these visits with the patient saying, look, at the end of the day, if you decide you don't want surgery, I'm the last one in the room that's going to argue with you about it. It's not standard of care. It's ultra aggressive. So a lot of this comes down to what is this patient, does he want to be really aggressive? In which case I would consider offering him surgery. You'd have to go through the rest of the testing and so forth. But right now he's treading water, and if he's happy with that, and he's obviously has a reasonable quality of life, then I think that it's fine to continue doing what you're doing. But if he's of the mind that I want to be super aggressive, I personally would think that surgery, it would be worth having the discussion with him.
Other thoughts? Feel free to give constructive criticism.
Also, I cannot in my wildest dreams envision being able to achieve a complete macroscopic resection robotically, because I do this operation to get the tumor off the surface of the lung requires inflating the lung to do it, at least the way I do it. So I would be worried about having
gross tumor left behind.
Yeah, I agree with that. I think a robotic approach to targeting this tumor is very unlikely to achieve our goal. And the goal is MCR, macroscopic complete resection. It's defined as removal of all visible and palpable disease that is clearly associated with better survival. So our goal is not to eliminate incisions, our goal is to eliminate tumor. And if we compromise on that, surgical outcomes will not be adequate, no matter how we get there. I do a lot of robotic surgery, but don't think it's appropriate for a case like this. And then lastly, I think talking about this patient specifically, this is an unusual situation. And this patient situation is important because it shows what we see as clinicians and what you deal with as patients, and shows our limits of our trial. Our trials show this patient had progressive disease after one treatment, therefore we treated and we showed some response. But how do you incorporate a patient who initially got cis-PIM approved in 2004, then added Pembro, not quite approved, had a bit of response on chemo, then progressed, then didn't progress on chemo immunotherapy, and then draw a conclusion from that? It's essentially impossible. Right. So I think we've got to set some baselines, and the baselines are going to show us what comparison should be. Dr. Sterman has talked about randomization, and when patients are not randomized, they're put in a single arm study such as a phase 2 and all receive one treatment, and the comparison is compared to history or other tumors. If you look back at the median survival of the original chemo article, it was 12 months. If you look at the current studies, the control arms are the same regimen, and they're significantly higher, up to 16 months. So if we're comparing back to 2004, I think it's no longer a standard. And fortunately, patients have done better with surgery, and they have done better with chemo.
Friedberg.
But across the board, these newer trials have had median survivals about 18 months. Checkmate 743 with combined immunotherapy, MAPS with adding Avastin, they're all about 18 months. And then what we saw in Mars 2, which still has a lot of data to be vetted, the median survival was 19 months. The original, one of the major original trials was in 1999, before patients were selected appropriately by Dr. Sugarbaker. The median survival was 19 months. Now, our data that's coming out with the new staging system is showing that the median survivals can be 29, 30, or even higher in surgical patients. So we have a more modern baseline. So if we do look at phase 2 trials and they're compared to data from 20 years ago, I think that's no longer appropriate. Our historical control should be basically 2017 and onward, so that we're speaking about how patients with the modern regimens do, which fortunately has improved substantially.
No, I think it's a very good point. The only other point I would make is that I think as much as we can, I know that it's not easy to do so, is I think we need to determine upfront if we're going to take someone to surgery or not. And the reason being, it gets a little confusing to try to figure out what we call the contribution of components, right? What is helping someone when you start with chemo and then you add immune or you add all this? And I've done that. I've been guilty of doing that in practice as well, right? Where I did it last week, where we did 2 cycles of carbopem and then we're like, well, it's stable, let's add durvalumab. Let's add something, right? But I think that this is why we like clinical trials, to get back to the question of clinical trials, because to really document whether or not people are benefiting from that type of approach, you have to do it in as rigorous a fashion as possible, right? And and that's the reason when I gave my talk, I said throughout it, your doctor might do something different, right? Even the question of maintenance pemetrexed, right? Whether to continue it after 4 rounds. I think we have nice data that suggests that it might not benefit most people to do so, but I still have colleagues who do it, right? And people who feel like it's helping the cancer and you want to do more at that point. And so I think that, this case to me just highlights how individualized our treatments are and how we need to invest at the same time in clinical trials, but we also need to listen to the patient in front of us too, right? Maybe in this case that was the appropriate thing to do, like to add the immunotherapy based on the data that we've seen. And I think it also speaks to what the doctors were thinking there, right? Sometimes we have trials and our approvals haven't caught up to the trials yet, and we as doctors feel uncomfortable kind of not doing what we think might be a better therapy while waiting for the government or someone to approve the therapy. And so do I give many people in my clinic the combo of chemo plus 1 immune therapy? Yes, if I can get their insurance to say yes.
I'm going to make just a real quick comment and then end this. Everybody made great, shared great perspectives and viewpoints, and I agree with all of them. This type of case, at least where I practice, we would view as a window of opportunity to do the case surgically. You have a guy with indolent disease that has self-declared biologically. He's done well despite nodal involvement. He's got an epithelioid favorable histology. He has actually responded to drugs, and while the response to drugs has kept things stable, there's still tumor there. And at the end of the day, you know, if all things being equal, or the patient is either willing, healthy, and informed, this is one of those opportunities where I think you stand as a large community to gain a lot of information, both on the doctor and patient side for this type of particular case. This is a very interesting and nuanced presentation.
This is a great segue too. Let's hear about a surgical case.
Yes. Hi, Joe. So that's a great point, and you know, the quality of life thing. So Melissa Culligan, who's not here, is actually doing her PhD on quality of life studies related to patients having surgery for mesothelioma. I think it's something, you know, we've been focused on overall survival, controlling the disease, but not for this cancer where surgery is not standard of care. If you're talking about surgery, I think quality of life needs to be weighted equally with the extension of life. And that's a common question. That's something that we often face, and probably one of the best things for that patient, if I were to see him, I would have him talk to patients who have had the surgery, at least the surgery that I do. You know, it's different if you're taking a lung out or you're not taking, you know. So you try and find an analogous patient and someone who's got a comparable sort of state of fitness, and have him talk to them. But that's really, you know, to establish that connection is probably the only way he can have it in his mind. But like I said, you know, if at the end of the day, you know, he doesn't want surgery and he's thought about it, you know, that's, but people come in I mean, all the time, I hear patients, lung cancer, everything else, you know, I'm not gonna get him, you know, I'm not gonna get chemotherapy, you know, why is that? Well, you know, my sister's friend's cousin's mother knows this guy who lived down the street from someone who owned the fishing store, and he got chemotherapy and he lost all his hair and then he died, you know. And so, you know, they need to get it firsthand. And for someone concerned about the quality of life, and he may talk to one of these patients who's had it done, and he'll say, that's not for me, and that's fine. But I'd say at this point in my heart, I don't feel like he would be giving informed consent either for or against surgery without talking to someone that's had it done. Dan, did you want to do some? So I put together a couple of case studies, you know, mesothelioma is not mesothelioma is not mesothelioma. So I just put these sort of brief scenarios together, and maybe we could go down the panel and see what each person. So this is this one, a young patient with this very little amount of disease. So it's a healthy 43-year-old woman. She ran the Boston Marathon 2 years ago, and she did the Broad Street Run in Philly last year. She had a car accident. They got a CAT scan. Everything was okay, but they found these small nodules. And she saw Dan, who sent her for robotic surgery, and she had a biopsy. And that little tiny thing right there turned out to be sarcomatoid, pure sarcomatoid mesothelioma. So maybe we could just go down the line, what each person would counsel this patient or what you would offer. Taylor, you're first.
So this is a rare situation, and I'm sure that's why you put it up. Because sarcomatoid mesothelioma is a less common histology, and it historically has had the worst survival, and the patients struggled with this disease the most, regardless of therapy. There's an exception to that now I'll mention. But the first thing I would do is fully evaluate, get a CT scan, make sure lymph nodes are assessed, see what the extent of disease is. Because detecting sarcomatoid disease in an asymptomatic patient picked up with a car accident is really unusual. So most patients present with sarcomatoid with a symptom, chest pain, shortness of breath are the two big common ones, and then we treat. What we know is, I think sarcomatoid, the data in sarcomatoid has been the most interesting and the most impressive in the last 20 years. In Checkmate 743, which is the trial that showed the immunotherapy showed benefit maybe as compared to chemotherapy with ipilimumab and nivolumab, the median overall survival was about 18 months. The chemotherapy arm was 8 months, which was in line with prior studies. And so the increase was from 8 to 18 months with immunotherapy. That was the biggest jump in survival in mesothelioma of a trial that's ever been seen. So I think that immunotherapy has really become the standard in the frontline therapy. However, somebody with one spot in one location, I've never seen a patient like this.
Well, there's more, if you scan the rest, there's nodules sort of throughout.
Ah, so he's hiding things.
Yeah.
It's the gotcha scan.
It's minimal disease. The whole tumor volume's maybe 50 mils. It's just these, when Dan went in with his robot, what he saw was, that there was sort of studding of the parietal pleura and some of the visceral pleura, but it's really sort of just tiny little nodules sort of throughout.
Would you treat?
Would you offer the patient surgery?
In an early stage, young, healthy, fit patient, I would offer her surgery.
And would you save the lung or take the lung?
I would save them, almost never take the lung.
Okay.
Yeah, I think to me, so it's a young patient, has a sarcomatoid histology. I think that maybe, we talk about something called lead time sometimes, right? I think that maybe we're just catching it very early because of the car accident. I would worry that, no disrespect to my colleagues, but I would worry that no matter what we did locally, that this cancer is stubborn and it would find some way to come back. And I would also kind of have a little bit of reservation about the sensitivity of my available tools in terms of detecting the disease, right? So a PET scan. And so you have to have a certain amount of tumor volume. And I say that to say that I think that we're underappreciating the volume of disease. And so this is a patient that she's young, she's healthy. I probably would give immune therapy with or without surgery, because I think that perhaps this is our opportunity. The thing that we lose sometimes when we talk about medians, when we say the average person lived this long versus this long with this therapy, is that immunotherapy, and the reason that we like immunotherapy as medical oncologists is that there's a tail on the end of the curve sometimes, right? There are some people who are here many, many years later, and we right now don't know who they are, but maybe that's this lady, and maybe by giving her the immunotherapy now, her immune system, when there's a lower burden of disease, can now start patrolling the body and try to figure out what it needs to be attacking. And so to me, this is an excellent candidate to give a doublet of immunotherapy, cross my fingers and hope that she tolerates it. And it might be less work for her immune system to do it now at the volume of disease versus trying to have it battle a lot of disease in her body.
So
this goes back to our conversation about can and should. Right, so there's no question that we have 3 superb surgeons here in the audience that they could get a macroscopic complete resection on this patient, unless there's a lot of hidden disease that we're not seeing used on PET CT scan or other workup that the patient has. The question is whether that's the right thing to do. It's important that if you look at the medical literature, and obviously the medical literature is not the sum total of all knowledge, but it's where we base our decisions, there's never been a surgical trial showing any benefit to a patient with sarcomatoid mesothelioma. Period, end of story. So if I'm discussing this with the patient and discussing it from a medical literature perspective, I could say technically it can be done, but I don't think it should be done, and I would refer the patient to medical oncology.
Chuong, how about you?
Again, I always drop back to the opportunity to learn more. I think this is, again, a rare opportunity to learn a lot about a disease that we don't understand how it progresses very well. I acknowledge every comment is correct, is the literature doesn't support intervention in this particular subtype of histology, but again, being where I am a little bit biased in terms of gaining more knowledge. So.
All right. Now I'll give you the right answer. No. So I would be extreme. So one thing, every patient, especially with this cancer, is different. That's the way I think you have to look at it, because and this cancer is crazy. Sometimes, and these guys will tell you, you'll be operating and the cancer will be soft, almost jelly-like in one part of the chest, and another part will be like, like a piece of wood. Some places it peels off nicely, in some areas it's invasive. It's extremely variable, and so the course of these patients is as well. I would be, even with that, so I would tell you that even to take that out, it's going to be a big operation. And I would agree with Dr. Sterman. Outside of a clinical trial, I personally would not operate on that patient, with the exception that she got the immunotherapy and maybe 2 years later she's behaving, bizarrely, and it's sort of slowly growing and it's remained in the same place. At that point, I would consider doing something off protocol, but it would have to be that it's like every now and then there's 2 types of lung cancer, right? There's small cell, which is the one that spreads early and often, and then there's the non-small cell, which is the one that we operate on. But every now and then you take out a nodule and they go, it's small cell, and you call the pathologist, you go, no, you mean non-small cell. They go, no, it's small cell, because you have one that's behaving like the other. This would have to be, for me to operate on this patient, it would either have to be on a clinical trial or it would have to be behaving like an epithelioid, not like the sarcomatoid, which, as Dr. Sterman said, our studies and everyone else, we just really haven't seen a benefit of adding surgery to the systemic therapy. How about this one? So it's this patient, 82 years old, and let's put him between these two. Let's say he has about, you would guess, sort of a lower volume disease. He presented with a pleural effusion and shortness of breath, which is how a lot of these patients present here. Maybe I can find, here. This is how he presented. He presented with shortness of breath, and so this is actually an interesting scan. So this is the left side, this is the right side. The black thing is the right lung. This is a patient I took care of in Baltimore. This is the left side. All this gray stuff is fluid. That little tangerine there, that's the lung. It's all squashed down. Dr. Sterman talked about atelectasis. That's the lung all squashed to nothing. The heart is getting pushed over to the other side. See, this is the diaphragm, your breathing muscle. See how it's like a dome, which is what it's supposed to be. Look at this side. It's turned in like this, and that's the stomach getting squashed. And this explains a couple of presenting symptoms that you or your loved one may have had, where the patients who present with fluid like this have 2 things. One, they have shortness of breath, obviously, but the other thing is they can actually have what's called early satiety, or I take a few bites and I'm full. Well, no wonder. You got a 2-liter bottle of Pepsi pressing down on your stomach there. Of course you're going to get full quickly. So that's one of the reasons that intervening early to remove the fluid. But let's say that this is that patient. He's 82, but He still, he works in his wood shop. He walks, he has dogs. He goes for a 2-mile walk with his dog every day, slower than he used to. He's a non-smoker. He used to smoke a long time ago when he was in the service, which is where he had his exposure. And you biopsy, you drain this fluid, and you do some biopsies, and it turns out to be pure epithelioid mesothelioma. He does not have any obvious nodes, and he's 82 years old. Good 82, but he's, his kidneys, his liver, his heart, everything else is 82 years old. Taylor, what would you do?
Well, he actually, in terms of quality of life, he's most likely going to benefit from removal of the fluid. So that's a simple answer. There's several ways to do that. Usually the most simple is put in a catheter called a Pleurex that many of y'all are familiar with. It sits in the pleural space. You drain it about every day or every other day for a couple of minutes, and it keeps fluid down. But just removal of the fluid, he'll probably feel better. Without doing extensive workup, and my bias is operating on an 82-year-old is pretty rare, I probably would not. I'd put him on multidisciplinary tumor board, discuss with medical oncologists. He'd probably get systemic treatment, and we would just make sure the fluid is adequately drained so he can breathe adequately.
No, I would agree, and I think that one key point I hear as a medical oncologist is that you said his kidneys are his age, so I would presume that his creatinine clearance is not excellent, and that is something we think about when we think about the chemo I talked about. And so I think that if we're talking about systemic therapies, of course I agree with you fully that addressing that pleural effusion is kind of the primary strategy, but I'd probably be leaning towards immunotherapy as the treatment for this patient.
Dan, is he a candidate for a clinical trial in immunotherapy? He's 82.
Well, having gone through the entire 124 active clinical trials right now, and my eyes are blurry from having gone through that, I think there are only 2 trials that I know of, and I think it's Dr. Dusamili may be in the back, I think, perhaps, but he may have one of them, which is an intrapleural CAR T-cell trial, which is a phase 1 trial, which would not be my first choice for someone who's initially presenting with mesothelioma, presuming we've made the diagnosis. And the other is either an intravenous or intrapleural trial, again of CAR Ts at the University of Pennsylvania. That's it in North America right now. So we don't currently have, that's much to my chagrin, intrapleural therapies. So again, going back to the comments, we can control the fluid through any number of different means. We could put in a tunneled pleural catheter to manage the fluid. We could do a pleurodesis procedure by putting talcum powder into the pleural space after expanding the lung. That should be the first and foremost goal, to alleviate the shortness of breath and manage it. And there are lots of different ways that we can do that. I probably would do that and then have the patient go for a multidisciplinary evaluation.
So you would palliate him with a Pleurex catheter? Is that your preferred?
There's been many studies looking at the comparison between talc pleurodesis and tunnel pleural catheter, and they're about equivalent in terms of alleviation of dyspnea. So I think you have a choice discussion with the patient whether, if they don't want to go home with a tube for a few weeks, then you do a pleurodesis. If they don't mind, you can do that as an outpatient. I can almost do that in the office.
Chuong, what would you do? Is this a window of opportunity?
Yeah, no, this is probably where I step off the bus, but the 82, so the age group, and this issue of fragility, I think, is critical. And so I think in the general overall calculation, the general benefit of surgery is probably diminished in this particular case.
All right, you guys ready for the right answer again? So again, I would say every patient's different, and personally, my oldest patient is 86, and she actually holds the land speed record for getting out of the hospital in 6 days. It's usually closer to 2 weeks. By the same token, I've had patients in their 40s who have lived hard, and for lack of a better term, I would say are too old to have surgery. I would have the conversation with him if he's in good shape, and we did all the testing, and it looked like he would tolerate it. Older patients tolerate surgery; they don't tolerate complications. And you'd have to understand going in eyes wide open about terrible things that could happen. But if he had low volume disease, epithelioid, he was in good shape, and was of the mind to be aggressive, I would at least have the conversation with him. I would not summarily dismiss him based on his age, but you know, the stakes are obviously higher.
I get to give Dr. Friedberg the hook, which I've wanted to do for the last 25 years. But this session is overdue, overrun, but it's been fantastic. I hope you've enjoyed the interesting discussions, the different opinions that we've had. Thank you for the audience for your fantastic questions. I think we have a small break right now, Maya, so grab some coffee, some snacks, and then another fantastic session coming up. I'd like to thank the panel, Dr. Ripley, Dr. Dagogo-Jack, Dr. Friedberg, and Dr. Hoang for all being amazing and for never agreeing with anything that we had to say.